Hello, in this video I'm going to talk about the risks associated with radiation exposure. There are a couple of models for this, and I'm going to go over those, the basics of those. And I'm also going to talk about how we monitor the dose that people receive, especially personnel. Here we go. When talking about the risks of radiation exposure, an important report to know about is the BEER-7 report. That's biological effects of ionizing radiation. And they go over the deterministic effects. These are things that we know are going to happen at relatively high doses. It's determined. So listed here, 5 sieverts bone marrow effects, 10 sieverts GI effects, and 20 sieverts CNS. But in addition to these deterministic effects, we have things happening at lower doses, and those are more random. So those are called stochastic effects, and the main effect is a radiation-induced cancer that can happen. So we want to have a model for the excess risk from exposure, and the model that the BEER-7 report advocates is the linear no-threshold model. And they conclude that there is no evidence for a lower threshold. So let's look in a little bit of detail at what that model is and where it's derived from. So what I'm going to do here is plot risk of cancer versus dose. And this is the excess risk of cancer. Remember, there's sort of a background rate at which people get cancer. This is excess risk. And this is excess dose above some background dose. So there's really no data below about 100 millisievert. But above that value, we do start to get data. And so I put the points here. These are largely data from nuclear bomb survivors, Hiroshima and Nagasaki. But what about this area, a low dose? We don't know much about it, so what is the model for that? Here's one possibility. You might start out without much happening at low dose, and then you get an increased risk. This is sort of a threshold model. There's some threshold above which risk kicks in. Here's another model. This is actually where you get an excess risk at low doses. It's a hypersensitivity model. Or you could even have maybe a benefit at low doses. Radiation is beneficial. This is radiation hormesis. There's no data to suggest one way or the other, so it's possible. And this is a straight line. This is the linear no-threshold model that the BEER-7 report is advocating. So basically, because of the lack of data at these low doses, we use this kind of middle-of-the-road conservative model to estimate what the risk might be. So building on this, we can then start to say what are the allowable ranges, limits for dose. These data are from the NCRP report 116, which is what is followed in the US. And you can see there's two different categories. So one, occupational limit, that's people working in some field that has radiation exposure. And then two, a public dose limit. So I'm going to walk through these. These are numbers that you should know and remember. First of all, for occupational limits, there's stochastic, these random effects, where there might be some excess risk, mostly of cancer. The limit for that is 50 millisievert in 1 year. And there's also a cumulative limit. There are also deterministic effects that have limits, so the lens of the eye, the skin on the hands and feet. Now, shifting to the public, the limits are lower to protect the non-work years. Continuous exposure, the limit is 1 millisievert in 1 year, about 50 times lower than the occupational limit, although there are exceptions for infrequent exposures, 5 times higher than that, 5 millisieverts. Again, deterministic effects. And then the final category is for the embryo or fetus, and the limit there that's given is 0.5 millisieverts, equivalent dose, in a month once the pregnancy is known. So to put these numbers in a bit of context, let's look at what the rate of background exposure is. In the US, the rate is about 3 millisievert per year. So that's about 3 times higher than the public dose limit that I just showed you on that table, 1 millisievert per year. In addition to that, There's also about 3 millisievert per year per person in exposures from medical tests, and that's largely from CT scans. So if you have these allowable dose limits, we should have a way to measure or monitor the dose that people are receiving, and we do, so I'm going to go through that. The recommendations can be found in NCRP Report 102. They recommend that you monitor people whose dose might exceed 10% of the dose limits on the tables I showed. The device should be visible. It should be on the trunk above the waist. If you're undergoing a procedure as a patient, you should not wear this device while you're doing that. And the user or the person in the clinic should be notified in writing if the exposure is greater than 10% of the limits. So here's what these devices look like. This is the film badge worn on the trunk. It has embedded OSLDs in it. They used to have film, but now it's largely OSLDs. There are also ring badges, and you wear those on your hand like a ring, and those are used to monitor dose to the hands either during fluoroscopy or during brachytherapy procedures. So the final topic in this video is the criteria for releasing patients from the hospital after they've received treatment with radionuclide or a brachytherapy implant. This comes from the new reg document, which is an NRC document. And the criteria are listed here. In this table, example shown is for an I-125 implant or for a palladium-103 implant. And the rule is that you can release the patient if the total implanted activity is less than that shown in column 1, or the dose rate is less than that shown in column 2. That's the measured dose rate at 1 meter from the surface of the patient. I'm going to switch here to the SI units and show you that. There are additional criteria in terms of instructing the patient, and there are other tables in the report that describe that, but basically, if the levels are about 20% of those listed here, you have to give instructions to the patients and tell them how to limit the dose to other members of the public and their family. Now, there are other ways that you can release a patient that are somewhat more complicated. You can do a very specific calculation of dose in the patient and to the public, and the release would be allowable under regulations. All right, so with that, I'm going to leave you with a little bit of further reading, if you care to. And then in the next video, we're going to get into how this plays out in the radiation therapy context. And in particular, how do you build shielding around a therapy unit in order to limit the dose exposure that staff and members of the public will experience. Okay, see you in the next video.